Welcome, everyone. My name is Pam Fury. I'm System Manager for Clinical Documentation at Alameda Health Systems. Today, we will not have education regarding just a clinical topic, but we will take a quiz together as a group to cover a lot of the education sessions that we have gone over the past. If any of you happen to have the laminated pocket guide, the tip sheet that we provided for all the physicians, many of the answers are in the pocket guide, and that would be useful. But we will do this together as a team. Question number 1. Which of the following are goals of the Clinical Documentation Department? A. To ensure the clinical language is documented as diagnostic language. B. To ensure the quality of care provided by the physician is captured. C. To make the physician's life more difficult. And D. To ensure the acuity of the patient is reflected in the medical record. There's more than one correct answer, although I know you might believe C is a correct answer, because it might be what gets accomplished, but that is not the goal of the CDI department, to make the physician's life more difficult. But yes, A, B, and D are all correct answers. Number 2, what are popular online sites for the consumer to research physician and hospital quality? A, CMS Compare, B, Rockadoc, C, Leapfrog, and D, Healthgrades. The incorrect answer is Rockadoc. That's just a site that I made up, does not exist. But CMS Compare is a Medicare site, Leapfrog, and Healthgrades. Those are all public sites that I encourage you all to go on and look at the hospital quality scores, usually a star rating, stars from 1 to 5 ranking, and then look up your own physician public data on CMS Compare, Leapfrog, and Healthgrades. B. Indicate the name and significance of the following. A CC, and an MCC. This is also on your tip sheet. So a CC is considered a comorbid condition, and an MCC is considered a major comorbid condition. And really, these are diagnoses of diseases that the patient has in addition to the primary diagnosis, in addition to the PDX. A major CC being more severe than a comorbid condition, and they can be chronic or acute. B, DRG. DRG stands for diagnostic related group. So when you have a patient that has an encounter in an acute care hospital, they have many different diagnoses listed. They all roll up into what's called one diagnostic related group, and that DRG is what gets reported to the payers, and takes into consideration what the primary diagnosis is and all the comorbid conditions. C, HCC. An HCC is a hierarchical condition category. It's really a phrase and methodology that's used in an outpatient setting, not quite yet in the inpatient setting. And it's used to measure the burden that any one given patient puts on the healthcare system. So the burden of the illness and the type of resources that are required to care for that. I will explain more about that later in another presentation. D, SOI and ROM. SOI stands for severity of illness. ROM stands for risk of mortality. These are very key. The maximum is a 4/4 that you can get. Typically, a patient expires if their SOI ROM scores are 4/4. And it's very important, as question number 1 asks, that we capture all the diagnosis that the patient has properly so we can properly reflect the severity of illness that the patient has and the risk of mortality, which leads us to E, OM and EM. OM stands for observed mortality, and EM stands for expected mortality. So observed mortality is what is reported by a healthcare facility, a hospital, and you as a physician, how many of your patients have expired. The EM, the expected mortality, is really sort of a cohort group comparison against your type of medicine that you practice and or your geography and the types of patients that you care for. So you typically want your observed mortality, which is the actual patients who expire, to be less than your cohort group's expected mortality. 4. Is it acceptable to indicate likely, suspected, or probable when writing a diagnosis? True or false? The answer to that is true. And we actually encourage that because remember that when you're writing your medical record, it's a progression of care for the patient and find a progression of findings for the patient. So in the very beginning, within the first 24, 48 hours, you might not know for absolute certainty that this is a diagnosis, so you could put likely, suspected, or probable. And as the patient's stay progresses and you rule things out and rule things in and begin to treat, then you will know that the patient has that actual diagnosis. But likely, suspected, or probable is acceptable to write in front of a diagnosis. That is true. 5. Writing syncope or shortness of breath is an acceptable final diagnosis. Yes or no? The answer is no, but there is a caveat to that. And why would you not want to write syncope or shortness of breath? That's because they are symptoms. They are not really a final diagnosis. There's something underlying that's causing the syncope or something underlying that's causing the shortness of breath. The goal of the patient being in the hospital is for the healthcare staff to determine what the etiology is causing the symptom and to treat that. However, there are many times, especially with syncope, that a patient comes in and an extensive workup is done to figure out the cause of the syncope. So periodically, it's okay if your final diagnosis has to be syncope, etiology undetermined, workup included. Okay, so 6. Which of the following is correct when documenting your differential diagnosis throughout the hospital stay? A, it is only necessary to indicate the differential diagnosis in the H&P. That's false, right? You want to start ruling out your differential diagnosis throughout the record. B, the status of each differential diagnosis being considered does not need to be updated. That's absolutely false. That makes for a very messy medical record. The status of each differential diagnosis being considered must be updated throughout the medical record. C, indicating the status of the differential diagnosis daily as ruled out, resolving, and resolved is best practice. Is absolutely what we like you to do. So as you're ruling out, you might have a list of probable 4 different diagnoses. As you go throughout the medical record every day, we want you to indicate it's resolving, it's resolved, or it's been ruled out. D, it is only necessary to indicate the primary diagnosis in the discharge summary. No, again, that should be throughout the entire medical record, what you believe the primary diagnosis is. And just as a FYI, the reason for the patient admission is not necessarily always the final and primary diagnosis that goes throughout the medical record. Okay, number 7. Thorough documentation of the patient's acute and chronic diagnosis helps to, we'll answer each one true or false. Documenting the acute or chronic diagnosis helps to capture an accurate severity of illness and reflect the complete disease burden. That is true. We discussed that in a previous question. B, by documenting the acute and chronic diagnosis, it helps to measure the risk of mortality of any patient, regardless of the reason for admission. That is also true. By documenting the acute and chronic diagnosis, it helps to authorize more days the patient can stay in the hospital to receive care, so to extend their length of stay. True or false? That's true. And finally, by thorough documentation of the acute and chronic diagnosis, it helps to hire more resources and equipment by reflecting the resource consumption needs for that care. True or false? That's true. So this is an important question because by us capturing your documentation and your diagnosis completely and thoroughly, this is what we accomplish by doing that. Just 4 of the many benefits by documenting properly. Question number 8. Which of the following would you prefer to have published on your physician report card? Would you prefer that your expected mortality is greater than the observed mortality, so that your whole cohort group's deaths are more than the deaths that are observed by you and your healthcare facility? Yes, that one you'd prefer. B, that your observed mortality is greater than your expected mortality. that your expected mortality is equal to the observed mortality. And D, documenting all chronic and acute diagnosis does not impact the reporting of patient deaths. So as I mentioned, A is what is most desirable to have published. You certainly don't want your observed mortality, how many patients have died under your care, to be greater than your cohort group. But C, if they're equal, if the amount of patients that expire under your care and our hospital's care is equal to your cohort group, that's acceptable. But the most desirable is A, and D is absolutely incorrect. By documenting all the chronic and acute diagnosis, it really does impact the reporting of patient deaths, because you don't want a patient that appears to be healthy, because we did not capture all their diagnosis, to then be reported as having expired. And that's what that SOI-ROM does for us. That severity of illness and risk of mortality score goes up to a 4/4 and reflects the true acuity of the patient. And so, again, you do not want a healthy patient expiring and that being reported on your physician report card. Number 9, the patient medical record is an evolving story of patient findings, treatments, and diagnosis that has a beginning, a middle, and an end. That's very true. And we've talked about that many times, that when they come in, you're doing a workup and doing treatment. And at the end of the day, then you will be documenting your conclusion and your findings as the patient record evolves. Number 10, writing alcohol abuse or substance abuse is an acceptable diagnosis. Yes or no? Let's start with alcohol. Is alcohol abuse an acceptable diagnosis? The answer is no. What is the preferred way to document and capture that diagnosis? By using the word delirium and not abuse. So if you have somebody come in with an alcohol issue, and you order a CDI scale to watch for tremens, hallucinations, withdrawal scores, it's acceptable and preferred if you can write a diagnosis such as intoxication delirium, withdrawal delirium, or you could write alcohol abuse with delirium. If you include, you just need to include the word delirium. If the CDI score, and you're really monitoring, assessing, and treating possible delirium. And substance abuse. Is it acceptable diagnosis to write substance abuse? And the answer is no. The preferred way to write that diagnosis is dependence. And just a hint for you, you can look at a patient's MAR and look for chronic pain meds. And you could write substance abuse or drug abuse with dependence, but you need to add the word dependence, even if it's an active or chronic use of like opioids or stimulants or Norco or methadone. All of those things are substance dependence or drug dependence. Okay, next question, number 11. Which of the following are correct when writing a diagnosis for depression? A, it is helpful to review the patient's MAR for home meds used for depression. B, many patients admitted for an acute mental illness may or may not have a mild chronic depression. C, it is not necessary to indicate if depression is chronic, recurrent, or single episode. And D, severity and type must be indicated in order to capture depression as a valid diagnosis. So the answer to this question, and also number 10, is on your tip sheet guide on the very first page under social and dependency. So for depression, it's actually a very good, useful tool to look at the patient's MAR. And if they're on home meds for depression, to 11B, the patients can have any type of acute medical illness, let's just say UTI, but they also can have a chronic illness, which is depression that they're being treated for. So it's acceptable to write mild chronic depression, the patient's problem list, as a diagnosis. It most often gets overlooked. That's why the MAR is a good tool for you. And C is incorrect because it is necessary to indicate if depression is chronic, a single episode, or recurrent. Typically, a patient is not admitted to a medical unit if that's their reason for admission, if it's like a single episode or a crisis for depression. But a chronic or a recurrent episode happens very frequently, and especially you see this in a lot of elderly or on antidepressant medications, and they might have mild chronic depression. And then the severity and the type, which is what that is, the severity is the mild and the chronic is the type, is indicated in order to capture it as a valid diagnosis. Number 12. Please fill in the blanks to complete the proper sepsis diagnosis. The answers to this are also on your tip sheet under sort of on the back under infectious disease, which is the gray area. So there's 3 things that must be documented when documenting sepsis. You need to document the criteria or the evidence. So A, sepsis as evidenced by 2/3 of what criteria? So it's 2 out of 3 of the SOFA criteria, which is a newer criteria, or it's really 2 out of 4 of the SIRS criteria. And SIRS is only still acceptable for use of a patient that's a Medicare patient, but all other payers want to use the documentation of the SOFA criteria when you diagnose sepsis. B, to document sepsis properly, you must document sepsis likely due to the underlying what? So sepsis typically doesn't occur without an underlying infection, right? So you need to say it's likely due to UTI or pneumonia or wound infection. Sometimes it could be due to a multifactorial infection. So you could write sepsis likely due to underlying multifactorial infections, UTI, wound infection. And lastly, proper sepsis diagnosis C. Blank is related to the patient's sepsis. You must indicate there's organ failure when using SOFA criteria to document sepsis. So if a patient has ATN, you must relate it to the patient's sepsis. So ATN is related to the patient's sepsis. You don't have to say it's due to, but you can say it is related to. So all 3 of those criteria need to be documented when you're documenting a diagnosis of sepsis. Question 13. Which of the following are correct when documenting excisional debridement? If done at the bedside, no procedure note is necessary or required. True or false? That's false. If excisional debridement is done at the bedside, there's always a procedure note that's necessary, or we cannot capture the procedure that was done by the physician. B. Writing the word sharp is not an accepted diagnosis. It must include the word excisional. So when you're documenting excisional debridement and you're documenting your procedure note, you absolutely must write the word excisional if it was excisional. If you write the word sharp without the word excisional, it is not an accepted diagnosis. C. Is C true or false? The depth of the tissue removed is required in order to capture the debridement procedure. That is true. And you document it as through the tissue, through the muscle, or to the bone. So it's best if you document through the level that you debrided through. And true or false on D. It is best practice to indicate the removal of devitalized tissue in the procedure note. Yes, it is. Just document that you remove devitalized tissue or eschar or necrotic tissue, something of that sort. Number 14. When a patient is readmitted to a hospital within 30 days of discharge for decompensated CHF because they could not afford their medication refills, it is advised to document non-compliant due to lack of financial resources. The answer to that is true. We encourage you because there are many diagnoses that if a patient is readmitted with the same diagnosis within 30 days of a discharge, the hospital does not get paid for caring for that patient. So a lot of times you can have some ESRD patients that miss their dialysis because they don't have transportation. Or hypertension reoccurs because patients didn't refill their medications. So it's very important that you just indicate that the patient was non-compliant due to lack of something, so that it's obvious that the healthcare workers did do their job and the patient did get readmitted anyway. 15. Scenario. A patient was admitted from the ED for UTI and delirium, and they were found to have a blood pressure of 210/115. The hypertension was treated with IV labetalol in the ED and they were stabilized, and then they were admitted with PO antihypertensives to the inpatient. The admitting physician should include the diagnosis of hypertensive urgency in the problem list. True or false? This is not a trick question, but the answer is true. Anytime a patient comes into the emergency room for a comorbid condition, which the hypertension was here because they had UTI and delirium, and it gets stabilized but still has to be monitored when they're admitted as an inpatient and still is being treated when they're admitted as an inpatient, that's still a problem that you're addressing. You're still ordering their antihypertensive PO meds and you're still checking their blood pressure. So that treatment, even though it was stabilized, that problem still exists when they're an inpatient. So that is a problem you need to list on the problem list, and you can say resolving or resolved but monitoring and treating. Number 16, this is our last, and we're going to go through each one of these conditions and indicate a proper likely diagnosis for an incomplete condition. So notice I use the word condition. These are not a diagnosis because they're not written properly. And what we can do is we'll go through and talk through what is the proper way to write this diagnosis. So the first one is congestive heart failure. Congestive heart failure by itself is not an acceptable diagnosis. If it was just a comorbid condition in a CC that's less severe, it would be like chronic systolic or diastolic CHF. If it's more severe, it would be acute systolic or diastolic CHF or acute on chronic. Renal insufficiency. A less severe insufficiency is a word you can never use when you write a diagnosis, but the patient could have AKI as a less severe renal condition, or they could have ATN as a more severe renal condition. Anemia. You could have acute blood loss anemia expected in a surgical procedure, or you could have hypovolemic shock that was due to anemia. Weight loss. A less severe diagnosis would be either underweight or non-severe malnutrition. A more severe diagnosis would be severe malnutrition. Chest pain. Chest pain is a symptom. It's not a diagnosis. The patient could have costochondritis as a less severe, or they could have NSTEMI type 2. They could have demand ischemia, but a more severe would be myocardial infarction. Abnormal labs. So abnormal labs is not a diagnosis even if you list out the lab. So you would have to write hyponatremia or hypernatremia or pancytopenia. A more severe one would be something like pancytopenia due to chemo or radiation. Bedbound or weakness. A less severe would be like hemiparesis. A more severe might be functional quadriplegia. Sacral ulcer. On a sacral ulcer, you need to write the stages and the location. So sacral ulcer by itself is not a diagnosis. So you would write sacral ulcer stage 2 or stage 3 or stage 4. Stage 3 or stage 4 would be more severe. And the type. It could be a pressure ulcer or a diabetic ulcer. But you must stage it and write a location. Respiratory distress. Distress is a word just like insufficiency. It is not a diagnosis whatsoever. It's a symptom, so never write it as a diagnosis. So the patient could have chronic hypoxic respiratory failure as a less severe diagnosis, or they could have acute hypercapnic or hypoxic respiratory failure as a more severe diagnosis. So you must talk about respiratory diagnosis as acute or chronic and the type that they are. Or it could be pulmonary edema or something else that's causing that symptom. SIRS 2 out of 4 criteria met. So um, a less severe diagnosis, it could be just sepsis with the other criteria we talked about, or it could be septic shock. And because SIRS is also still a symptom. Those are 4 different symptoms or 2 out of 4 symptoms that a patient has, and it's not always due to an infection. So SIRS by itself is not a diagnosis. Chest x-rays with opacities. A less severe diagnosis reflecting that finding is pneumonia. And a more severe diagnosis would be something like aspiration pneumonia or pneumonia due to gram-negative bacteria. Hypertension, a less severe diagnosis for hypertension would be, and this is all these things are on your tip sheet by the way, could be hypertensive emergency, Actually, that's more severe. So you could have hypertensive urgency as a less severe, or you could have hypertensive emergency as a more severe, or hypertensive encephalopathy as a more severe diagnosis. Altered mental status. So altered mental status is also on your tip sheet, and it goes through the different causes of altered mental status. But you could just have something like acute delirium as a less severe, or encephalopathy as a more severe. And there's different types of encephalopathy. And when you're writing delirium or dementia, when there's patient has altered mental status, it's very important to indicate if there's behavioral disturbance. So you can write acute delirium or acute dementia with or without behavioral disturbance. And how will you know that? If you have to order anything like Xanax or a sitter or restraints, obviously there is some behavioral component there that you can document. And then appendicitis. Appendicitis usually has some conditions that occur with it that are typical. So you could write acute appendicitis as a less severe, but then you could also write as a more severe acute appendicitis with peritonitis, because most typically there is a local inflammation into the abdominal region when you have an appendicitis. So very good. That's a lot of information. It's information that we've covered, over the last many months. And if you all use your tip sheets, in your pocket guides, you will know the answers to this at every moment when you're documenting. Thank you very much, and feel free to call any of the CDI specialists for any questions related to this. Have a good day. As you know, we are a team and we play nice together. Thank you.